Good morning, good afternoon, good evening, wherever you are logging in from. Welcome to this very special summer edition of Facebook Live Neurology for Vets webinar series, sponsored by Hallmark Veterinary Imaging. Now, for those of you who have seen these webinars before, usually you will know that usually we run them for rising stars of the veterinary neurology world. But today we have a fully fledged star of the profession. And it is our honor to welcome Dr. Rita Goncalves.
Oh, that was very good.
Oh, sounds good. Okay, I've been practicing. And she's going to be talking about a recent publication, work on MRI prognostic factors for survival and relapse in dogs with meningitis of unknown origin, or MUO. And now a short introduction for Rita. Rita graduated from the University of Lisbon, Portugal in 2003. Now a natural move, as everyone knows, from Lisbon is straight into Yorkshire, England. Kind of the same sort of place where Rita worked as a small animal practitioner. And then she undertook an internship at the Animal Health Trust during its glory days in Newmarket. Rita completed a residency in neurology and neurosurgery at the University of Glasgow, along with a master's. She is a European and RCVS recognized specialist in neurology and heads the neurology and neurosurgery service at the University of Liverpool, where she works as a senior lecturer. Not busy enough with that, she has undertaken a part-time PhD investigating non-invasive biomarkers in dogs with meningoencephalitis of unknown origin, and inflammatory brain disease is her main research topic. She is the perfect person today to talk about her work and recent publication. So thanks, Rita, for coming. We really appreciate it, you giving up this time. And I want to hand over to you so you can get started.
Perfect. Can I share? Yeah, perfect. So I will start by saying thank you for having me. It's probably because of you guys that I'm a neurologist, because you inspired me so much. When I was an intern, I wanted to do medicine. And then I went to the trust and saw how much fun it could be in its glory days and decided neurology was the way forward. So thank you for having me. I'm going to talk about one of our papers that we published earlier this year, which was, as you said, in the prognostic factors for MUO, looking at MRIs. But I will do a little bit of a tour about MUO and a little bit about some of our other studies that are related as well. So I'd imagine most people that are watching this are quite versed on MUO and have treated it and have seen it, or at least have an interest in it. But as a bit of a summary, what we've got is a group of inflammatory non-infectious diseases that, as we know, cause quite a lot of severe neurological signs. Doesn't uncommonly result in death, quite sadly. And when it doesn't result in death, it often is associated with marked disability. And a lot of our clients tell us that it's like having a family member that's disabled. And it takes a lot of their time. They have to take time off to go to the vet. Dogs are often not go back to normal. They'll often have epilepsy associated with it. So it's quite a frustrating disease for the owners, definitely for the pets, and for us. Because we don't often know which ones are the ones that are going to do well, which ones are the ones that are going to do badly. And we don't really know how to tailor treatment properly. In terms of what causes MUO, we still don't know. We suspect it's immune mediated. It makes sense because it has a very positive response to immunosuppression. And the thought is that it may be similarly to some human inflammatory diseases like multiple sclerosis, is that there's genetic susceptibilities that are, at some point, there's an environmental factor that triggers the development of the disease itself. What that trigger is, we don't know. And in humans, for example, again, with MS, there's quite a lot of well-known triggers. One of them is viral, like the Epstein-Barr virus. But in veterinary medicine, there's been quite a lot of research. These are some of the latest studies trying to find that trigger, and they've all kind of failed. And there's a lot older ones as well that have all failed. So if there is a viral trigger, we haven't got to it yet. But it's quite likely that it's more complicated than that. And again, in MS, there's loads of other things. not just the viral trigger, but also, for example, where you live, things like having lower vitamin D levels, being far away from the equator, etc., living in cleaner countries with higher hygiene standards, etc. So there's probably a combination of things that we probably will take a lot longer to identify. In terms of genetics, what we know is that there are certain variations in certain breeds that are associated with the development of at least the necrotizing forms. And most of these variations are related to immune system regulation. So there's probably some kind of derangement. That means that when you get to that trigger, these dogs are more likely to develop clinical disease. So I thought I'd just mention a little bit the similarities and the comparisons that are currently quite often raised between MUO and MS, because there are a lot of parallels, and it would be very interesting for us as vets if we could propose MUO as a possible spontaneous model for studies in multiple sclerosis, because multiple sclerosis is very common, a very debilitating disease, a very expensive disease for countries, because quite a lot of affected people will have to stop working. So it's not just the hospital costs and the treatment costs, but also the loss of the working force. So it would be great for us as vets if we found more funding and if we found more interest in terms of treatment and diagnosis of MUO. So what are the similarities? The clinical signs are similar, although the frequencies are quite different. For example, we see a lot of seizures in dogs, whilst in humans, seizures are actually quite uncommon with MS. So there's definitely a different presentation, but the signs themselves are quite similar overall. And pathologically, there's a lot of similarities with the inflammatory cell infiltration. The main differences will be that in MS, the hallmark in pathology, the most important thing is going to be demyelination, whilst in MUO, although it's part of what we often see, is not the most important feature. So that is definitely one of the biggest differences between the two conditions. In MS, there's a combination of both T and B cell infiltration, whilst in MUO, it's typically mostly been described as being a more T cell mediated inflammation. There's been recently a paper looking at oligoclonal bands in dogs with MUO. Oligoclonal bands are often used as part of the diagnosis of MS. And it's common, it will be present in the CSF in more than 90% of people with MS, whilst in this paper, it was only shown in a bit over 50% of dogs with MUO, and also present in some dogs with other CNS conditions. But it does show oligoclonal bands are produced by B cells. It does show that there's definitely a B cell involvement, which was previously considered quite minor, and it's probably more significant than we thought. So that's good. It means it's a little bit more similar maybe than we initially thought. And there's a lot of similarities, probably more in our patients with necrotizing forms than in the patients with the granulomatous form. And for example, clinically as well, we see the dogs with granulomatous meningoencephalitis quite often have raised ICP, quite big swollen brains. That's not a feature of MS. In MS, you just have your different plaques with or without contrast enhancement, but swelling of the brain would be quite rare. And that's probably more similar to what we see in our necrotizing patients as well. So this table comes from that paper that I mentioned with the oligoclonal bands, and I think it's quite an interesting summary of the differences and the differences and the similarities between MUO and MS. And it's a good review, I think, for people starting to be interested in MUO, trying to think what parallels we might want to make. And also in terms of research, when I was planning what kind of things I wanted to do in my PhD, a lot of the inspiration, a lot of things I thought, oh, this might be interesting or that might be less interesting, were reading about human inflammatory brain diseases like MS and trying to figure out what might we learn and what might we want to explore. So one of our previous studies was looking at the presentation of patients with MUO, and we had a reasonably large population of almost 450 dogs diagnosed with MUO in 2 institutions, so with us and the IVC. And it was a useful, I think, kind of starting point to try to figure out how do these dogs present and what should we be looking for. And it does show a very mild female predisposition, but maybe less significant than sometimes it appears in the literature. But the other things are quite similar. So you've got your low mean body weight. So majority of dogs will be small breed dogs with inflammatory CSF. So one of the difficulties, I think, in doing research in MUO is defining MUO, and comparing different studies with MUO is quite different, because I find that almost all of them have slight variations in your inclusion criteria. So for most of our studies, we've used that they have to have inflammatory CSF. So currently in all of our studies so far, and obviously we know that has issues, because a lot of dogs with necrotizing forms will have normal CSF. So quite a large number, so about a quarter of pugs will have normal CSF. So we'll be excluding them, and that's obviously an issue. But we have to try to be careful that we're not including other patients. So I think we are at a point in time where we probably need a consensus, and there's so many consensus statements nowadays. Probably we're at the point where we need one from MUO, and we need to decide when we do studies, do we group everything together, or do we look at different subgroups of different combinations? So dogs with normal MRI and abnormal CSF, dogs with, abnormal MRI and normal CSF, and both of them abnormal. And I think we're at a point where that's well due and something that we need to investigate. So looking back at these patients, again, these are dogs with abnormal MRI and abnormal CSF. What we've got in terms of presentation of the clinical signs are what we'd expect. So a presentation of forebrain signs and often brainstem cerebellar signs. But we find the majority of dogs have multifocal signs, which is useful, because clinically, obviously, that's what we try to pick up. So we can try to think, yes, MUO is more likely, because, not many other things cause different areas of the brain to be affected. But importantly, she's quite a high proportion of seizures, and that we know over the years that that's a really important thing to treat appropriately, because that's significantly associated with outcome. So what does the literature tell us about survival? It's a little bit varied. So in this study, our study that I've just mentioned, we had about 20% of dogs not surviving to discharge, so dying within the first week or so, whilst previous studies have suggested that number is about 25 to 33%. So it's, even if we're maybe doing a bit better over time, still pretty bad that 1 in 5 are dying that early on. And then if they do survive that first week, then it tends to not drop as quickly. So what we have then is about 70% alive at 3 months, and then over 60% at 6 months. And then we're kind of dropping a bit more again towards 12 months. And that's probably associated, we're going to see when we looked at relapse, that about 50% of dogs relapse. And when they do that, our median time for relapse was about 7 months. So a lot of them will relapse within about 4 to 12 months period. And that will often result in euthanasia in owners that are frustrated, and when the severity of the clinical signs is quite concerning. So kind of in summary, this is why I think so many groups are doing research into MUO. So we're trying to do quite a bit at Liverpool, but there's loads of other groups around the whole globe that are looking at MUO. And I think it's because we're all frustrated. We don't know why some dogs respond to treatment and others don't. We don't really know what the best treatment protocol is. And that's definitely something that we do need to do better. Our treatment studies need to be a lot better. We need to have some good clinical outcome measures, not just survival, because that's so biased in veterinary medicine. An owner will put a dog to sleep because they can't afford it anymore, because they don't have time to go to the vets, or because they can't tolerate seizures, whilst another owner will carry the dog that can't walk for 6 months. So survival is really, really not a good outcome measure. We need to do better than that. And then can we predict a bit more which dog's going to do well or less well, so that we can then maybe tailor the treatment appropriately? So we definitely need to do better, and that's why so many people are doing studies looking at trying to figure out what are the prognostic indicators that we might want to use. So one of the first things we did, and I'm kind of introducing it because we then used this scale on the MRI paper, is we wanted to try to find a more objective outcome measure for MUO. And again, survival we thought was very biased and very difficult to interpret. So we wanted to develop a disability scale, and we tried to get inspiration from some human ones. So we mainly use the EDSS, which is the MS, the one most commonly used for multiple sclerosis. We also use the CASE, which is for autoimmune encephalitis. And the reason for that is autoimmune encephalitis is very commonly, the typical presentation is seizures. So we wanted to incorporate seizures because it's so important in our patients with MUM. So we developed this scale and we validated it, and then we've tried to use it in some of our future studies, and hopefully we will continue to use it, especially hopefully we're trying to do a treatment trial at some point, a placebo-controlled study if we can get the ethics for it, and we will use this as an outcome measure because I think that's important. So the scale uses what we found were the most common clinical signs in our patients with MUO, and we eventually had to fine-tune it a little bit because we found that, for example, we're terrible at agreeing whether a dog has proprioceptive deficits or not and whether dogs are painful or not. So we kind of took away the things that had the highest variability and that we didn't really agree, and we come out with this score system that the worst affected would have 21 points, and obviously you can have 0 if you've got no clinical signs. So we then tried to use that scale and tried to look at other things, looking at clinical prognosis for survival and outcomes. So looking at clinical factors first, and then we tried to investigate the MRI factors. And in terms of clinical factors, we found that seizures were, to be fair, the one with the highest odds ratio, so the one most associated with survival. And it's fair enough, a lot of owners don't tolerate it. Seizures are really quite severe as well and difficult to control. We found paresis that not found before, and importantly that the higher NDS score, so this disability scale, was associated with decreased survival. And that just makes sense. If you've got more neurological deficits, you're probably going to be less likely to survive. We did find that having a lower body weight and having a higher NDS score was associated with risk for relapse, which is different because not all dogs that relapse then died. A lot of them will survive anyway with just rescue protocols. But it does seem that the smaller breeds were more likely to relapse than the larger breed dogs, which I think probably clinically is something that we already had that concept. Looking at other papers from before, other things that had been associated with prognosis had mainly been younger age. We didn't manage to reproduce that, but I guess in humans and in MS, there's definitely ages associated with risk for relapse. And it's been found that early diagnosis within 7 days of onset of the signs was associated with relapse, with prognosis survival, as well. Seizures and obtundation were associated with risk for death. So different things have been shown. We didn't really find obtundation, which is surprising because loads of other quite a few different studies had found it before. But I think obtundation probably is one of those things that's a little bit subjective as well. Some people might consider a quiet dog to be obtunded, whilst others might want something a bit more severe than that. So quite likely obtundation is associated as well, but in our case, it was not. So in terms of relapse, as we said, what we found was that about 50% of dogs will relapse at some point, and we found that the median time for relapse was 7 months. And the things that we found associated with relapse was the higher NDS score, the incomplete resolution of the clinical signs. So it means if they didn't go back to being neurological normal, they were more likely to relapse, which I guess it makes sense. It never were completely under control. The disease was never completely under control. And dogs that had longer duration of the clinical signs were before they were diagnosed were also more likely to relapse. And that's interesting. There's a study that just came out over the last few weeks, I think, from the University of Taiwan, looking at dogs with necrotizing encephalitis. And they also found similarly that the dogs that presented with quite a long duration of clinical signs before diagnosis were more likely to relapse during treatment. So after that bit of an introduction about certain things that had been done before, we go back to this paper itself, looking at the MRI prognostic factors. So again, we want to try to find everything that we could use clinically, because we're clinicians, and although it's great to have lab tests that we could do, a lot of the times they're expensive and a lot of the times they're experimental and we don't have easy access to them. So what can we use clinically? And MRI is definitely something that we all use. What can we use to predict survival and relapse? And there'd been one previous study that had evaluated this, the Mark Lowry paper and Laurent's from a few years ago, where it was mainly looking at the use of cytarabine, but looking as well at MRI prognostic factors. And in that study, mass effect and signs of raised intracranial pressure were associated with survival. So we wanted to try to see if we could reproduce those findings and whether we can find something more. So our inclusion criteria was that dogs had to be older than 6 months, they had to have at least one lesion on MRI, and they had to have mononucleocytosis. We had to exclude inflammatory diseases in the region, which for us, this was an UK-based study between using cases from Liverpool and the RBC, was mainly Toxoplasma and Neosporin. So what kind of things did we try to link with survival and relapse? We tried to see if focal or having just one lesion or having more than one lesion was associated with outcome, and that had been looked at before with kind of different results, whether having contrast enhancement or not, whether having, again, signs of raised intracranial pressure like had been seen before. We also tried to look at the location of the lesion. So in humans, there are certain areas that are predisposed to worse outcome, and in humans mainly is the brain stem. So we were trying to figure out, would we find an association? So we divided into 3 major zones, similarly to, again, some human studies where they call it the superficial forebrain, so mainly your cortex, your deep forebrain, so mainly your thalamus, and then the caudal fossa structure. And then we used the dog brain atlas to divide it into 15 different regions, just so that we could then look at the distribution of the lesions a bit better. What we wanted to do, and this is again a little bit based in human studies with MS, is we wanted to see if the amount of disease that you have, so your lesion volume, was associated with outcome. And in humans, the T2 lesion load has been shown to be associated with outcome in quite a few different studies in MS. Now, if you look at the literature in MS, you will find hundreds and thousands of studies. So they'll all have slightly different results, but there's quite a few different ones that I found lesion load to be associated with outcome. So we did think it was interesting enough. So I very painfully measured all the lesions. It's quite a time-consuming job, but what I did is manually delineated the whole brain. So went through every slice on the MRI to delineate the whole brain volume. I then delineated the ventricular system so that I can take the ventricular system away, and then that gave me what I call the parenchymal volume. And then the harder bit, I think, was doing the lesion load itself, so delineating the whole lesion on T2, T1, FLAIR, and post-GAD, so that I can then get a ratio between that and the brain and the parenchymal volume, which I call the lesion load. And that at times was challenging because some of the lesions are quite ill-defined and quite time-consuming when they're big lesions. But this image on the bottom is from the article, gives you an idea of what it looks like, these masks that you can generate. So you delineate your lesion, and then you can calculate that ratio, and you can see on the legend, the figure legend, that that image on the left has got 3.3% of lesion load, whilst the image on the right has almost 30%. It's quite a severe lesion. So this is just off the internet, so I'm not using a mirror anymore at this point, so I didn't have any pictures to take you, but it's a very easy software to use. You just delineate your region of interest, again, slice by slice, and the software will generate a 3D image for you of what you've created, and it calculates your volume for you. So it is reasonably user-friendly for anyone to use, not particularly complicated, it's just time-consuming. So not unexpectedly, the lesions were hyperintense on T2 and FLAIR, and hypo to ISO on T1. We did have a fair bit of contrast enhancement, so about 3/4 of lesions had contrast enhancement, and quite a lot had meningeal enhancement, which was mostly diffuse. Sometimes it was not the whole brain, just a few slices, but it was affecting a large proportion of the meninges. And about a third of dogs had changes consistent with raised intracranial pressure. So it's reasonably common in our patients, again, compared to humans with similar diseases. In terms of location, we found that the white matter tracts, the corona radiata and the internal capsule, were the most commonly affected, which is interesting. Again, a fair bit of white matter distribution. And then we could see quite a fair bit in the brainstem, so mainly the medulla and the midbrain, and then less so in the cerebellum, with all the cerebral cortex involved quite commonly as well. So just to make sure that I was using the software okay, I tried to calculate how reliable my measurements were. So I repeated 10 random dogs a few weeks later. So I did all the measurements over a few weeks, and then I stopped and didn't do anything. And then a few weeks later, I came back and repeated a few measurements. And I was quite happily surprised to see that it was actually quite good reliability, with the ICC scores were quite high. And I guess, in terms of the ratio, it worked quite well. So quite happy to see that the measurements did seem to be consistent. So then what were our findings? We found that we tried to correlate the clinical signs, so the NDS score, with the images themselves, and it just makes sense that the higher your NDS score, and again it represents your clinical severity of your clinical signs, was associated with a higher load on T2, FLAIR, and T1. So that makes sense. The more lesions you have in your brain, the more clinically affected you are. So that was correlated. And then in terms of survival, we mainly found that a lower T2 load was associated with longer survival. So again, that it doesn't clinically, I guess it will make sense that if you've got smaller lesions, you're more likely to survive. And again, this is similar to human patients with multiple sclerosis and similar diseases. Now, we didn't find mass effect or any signs of raised intracranial pressure associated with outcome, which was maybe surprising, but I guess whether we're better at treating raised intracranial pressure, whether it's something that we're already kind of treating earlier on because we're worried and they're surviving, but we didn't find that association. And I just wanted to highlight, this is a paper that also came out quite recently from the US, looking at comparing dogs that have lesions on MRI and dogs that have no lesions at all, which again will still be in the classification that's oftenly used for MUO. They'll have abnormal CSF and normal MRI. They also didn't find a correlation with raised intracranial pressure and outcome in their dogs with lesions. They also found, interestingly, I guess something that we all expected, that dogs with no lesions on MRI have a better prognosis than dogs with lesions in MRI. Now, again, we didn't look at that because we're just trying to look at lesion load mostly. So all our patients had lesion, but in a way it's kind of related. So patients with no visible lesions do better than patients with visible lesions. So looking at relapse, we try to use, again, the same variables that we mentioned before. So location and raised intracranial pressure and all the different measurements. And the only measurement associated with relapse was a higher post-contrast load. So in this case, the T2 load that was associated with survival wasn't associated with relapse, but the contrast was. And we know that contrast enhancement is associated with blood-brain barrier breakdown and infiltration, inflammatory infiltrates. And in humans with multiple sclerosis, it's been shown that your lesions, once they're active, what they call the active lesions, will only contrast enhance for about 3-4 weeks, and then the contrast enhancement disappears. So the thought is that if you have more contrast enhancement, you have more active disease. And I guess that potentially is what we're seeing. Patients with big contrast enhancement loads have a higher active disease, so they might be harder to get completely under control. And we definitely have patients with huge T2 loads that had quite small amounts of contrast enhancement, and dogs with medium T2 loads where most of it enhanced, and a lot of the dogs with the marked enhancement did relapse at some point. So I'll let you all go and have your dinners with your families, but just wanted to finish by talking about the limitations of the study. And obviously there's quite a few, and again, coming back to what our definition of MUO is really a tricky one. Most of our studies are not comparable because we are using different inclusion criteria. For this study, and for, again, many other studies, the main limitation is that we don't use the same treatment protocol. And it is difficult to stick to a treatment protocol because each patient is different and each owner has different ideas of what they want to do, how many times they want to go to the vet, how much financial investment they can make. So the difference in treatment means that will quite likely will affect the prognosis. So just looking at the MRI, all the patients aren't the same. They've been treated differently. So that makes it a little bit difficult to make sure that it's just the MRI images themselves that are affecting outcome. We also had a huge variety of dog breeds. And when you look at MS studies, they often compare measurements, which we can't do because our head sizes are completely different. And also the different type of head. So the brachycephalics have quite large ventricles, and that affects the parenchymal volume. So it does mean we might be underestimating or overestimating the sizes of the lesion load because they have such different amounts of the parenchymal volume itself when they have these large ventricles. A lot of the lesions were actually quite difficult to measure. I'm not going to lie to you. They were very ill-defined, so it's difficult to know exactly where the borders were. And the contrast enhancement was often just little spots or little lines, so very difficult to measure accurately. They were quite small and difficult. So probably that will affect how, I guess the reliability came out quite well, but I might have just been bad all the time. The other main thing was the lack of histopath. And again, that's something that will always be a problem because we don't biopsy these guys and they often don't die. So it may well be that we treated diseases other than MUO, and it may be that some of the things that I measured as a lesion were periictal changes. I don't think any of the dogs just had periictal changes because they would have had multiple lesions quite often, but maybe some of what I measured that I thought was part of the lesion was actually just periictal. So quite a few different limitations that will definitely affect the results, but hopefully reasonably large number will make up for some of these. So I'm very happy to take questions, and I just wanted to point out that we still have a really long way to go with MUO because we still are not defining it properly until we classify it better. It's very difficult for us to know what we're comparing between our different studies. So we definitely need to try to work a bit better in cooperation and get better at diagnosing it.
Thank you very much, Rita. Really good presentation and really good study as well. We have a couple of... It's Simon's favorite dog.
Is it?
Yeah.
He's dreaming of having one like that.
I actually want to breed them, but that's for another time. And probably inappropriate to bring up, after a talk on MUO. But anyway.
I promise him I will send him one in the US. First question is from a good friend of mine, Andre, who is also a very good neurologist. Thank you for the great talk. My question is the relation basically between MUO and core vaccination? If you can share any light on that.
I have no idea. I don't know what everyone does. I suspect not, but I guess we don't know. We don't have the studies. No one has looked at it. What do you guys do? What do you recommend when patients ask you?
There was I avoid the question. This is my answer, but there was an abstract this year at ACVM that looked at this, not necessarily with revaccination, but with timing of vaccination and onset of disease, and didn't find a relationship between it. The question about should we then vaccinate the dog that already has it or is in so-called remission is still wide open. But based on this one study, it didn't seem that the core vaccination and the timing of it is related to an onset of it in that of MUO in that study.
Yeah, so I guess my answer would be there's no data that I know that is particularly strong to back yourself up. I have always, like you do, I avoid the question and then I put it back on the owners, where I would say there's a risk to vaccinating and there's a risk to not vaccinating and get an infectious disease. So we'll have a discussion, but there's definitely no evidence to say that there is a particularly strong risk.
Another question from Miroslav. Again, thank you for presentation. The question was mostly about how do you differentiate? So do you advise follow-up MRI? And if you do, how do you differentiate between active disease versus scarring, so gliosis?
So that's a really good question, and something that we are looking into as well. I have to say, so in humans, one of the most important prognostic indicators in MS is the development of brain atrophy. So if you have brain atrophy at diagnosis or on repeat scans, and they do repeat scans every year, you're more likely to go into the progressive form of MS, which is the more severe one. So, I mean, I think we've all seen dogs that with repeated MRI that have brain atrophy. So we now need to try to quantify it and see if we're better. What I would say is we used to recommend repeat MRIs at 4 months, based a little bit on the paper that I mentioned from you and Mark Lowry. And I can't remember any where I didn't see lesions at 4 months. So now we don't do that anymore because we've realized that we don't know if it's active disease or not. So we mainly, if owners are keen to do it, we do it at 12 months. And at 12 months, we find that majority of dogs still have lesions, but they're quite minor and they look a lot better. So at least it gives you a little bit of a better idea. So we do it, and we mainly do it if we're thinking about stopping treatment. But again, I think we need a bit more on that before we can do stronger recommendations. So hopefully that's one of the studies I will do next year.
Yeah, no, I agree. I mean, it's very difficult to know. There is always the odd dog where you see over lesion but were not present.
Yeah.
I presume if you see contrast enhancement, then it is definitely active disease. Well, if you don't see, it may or may not be active disease. So it's a positive finding, contrast enhancement. But again, it's not very common. You see contrast enhancement in follow-up MRI, to be honest.
Yeah.
So that's the other thing. I'm glad Simon is not falling asleep. I was just saying to, I see you make a really nice, comparison between MS and MUO. And just before we went online, I was making a nice comparison between Simon and is President Biden not falling asleep during a talk. I think
I managed not to freeze up.
No, not slurring yet. But another question from Andre: if there is no histopath, how can you be sure the contrast enhancement is not the sign of a diffuse tumor?
Well, I guess, so many things contrast enhance. So anything that breaks down the blood-brain barrier will contrast enhance, and obviously inflammation will. So the issue is not the contrast enhancement. The issue is we just don't know what the lesions are. I guess I don't have a proper answer for that, but the difficulty of doing histopath in these dogs would really bias the results if we only used patients with histopath, because they would be the dead ones. So all the ones that survive, we can use. I know there's a lot of people that talk about biopsying more of these dogs, but it's not without risk. It's not without cost. A lot of our owners wouldn't afford it. So, it would be quite difficult to move forward to a point where we only use histopath. So again, I don't know. I can't make sure they're not tumors, but I don't think just the contrast enhancement is concerning that they are not MUO.
I mean, for the ill-defined lesion, the main differential, I presume, would be gliomatosis cerebri. But this typically, but not exclusively, doesn't tend to enhance as well. So usually enhancement is not very common.
There's a
condition.
A nice paper from Tim Bentley on the MRI mimics for gliomas, and Tim now works here at Liverpool, which is great. And he was just saying how he's removed 2 MUOs, and you look at the MRIs and they really look like like gliomas. So there's definitely an overlap, and we'll always get a few of them wrong.
Yeah.
But we have to go with what we have.
No, absolutely. I think that's it, Rita. We've done it.
Yay!
Well done. Thank you so much for obviously giving your time and to see you again. I'm glad that Simon and I, we managed to put you on the correct path and you didn't get lost into becoming one.
What is wrong with me?
But we mentioned another one and I was actually shocked and relieved at the same time. But, you know, we've achieved something in our career, which is to put you on the right one, on the right path.
Can I use this to plug ECVN?
Of course.
Everyone come to ECVN in Porto. It's going to be great. It's going to be sunny. The food's going to be amazing. And the wine's going to be lovely. The talk's not going to be great.
No pressure.
Is that Portugal or is that Yorkshire?
So I worked in Doncaster. I always say Yorkshire is Doncaster.
Okay.
It's sunny Portugal.
ECVN is 13 and 14th of September in Porto.
Yeah. Thank you very much.
So definitely come.
Excellent. Thanks, Rita. Really appreciate you giving up your time. Thanks to everyone who's tuned in. We'll post a recording of this on our YouTube site and podcast channel. Thanks to Hallmark Veterinary Imaging for sponsoring today's webinar. Please join us again in September. That will be our next one. And until then, have a great summer.
Good night.
Goodbye.